about hypothyroidism, very few clinical pictures. So, but okay, I hope you learned some from this, and let's start. I'll start with the case, exercise intolerance. You decided to pursue hypothyroidism. The test results are as follows. Total T4, 0.8 micrograms per deciliter, reference interval 1 to 9. Free T4, bioequilibrium dialysis, 5 picomoles per liter, reference interval 6 to 42. And endogenous TSH 0.4 nanograms per ml, reference interval 0 to 0.38. So would you treat this dog for hypothyroidism? Yes, I will do a treatment trial. No, I will not. I will look for other causes. I will not treat this dog. I will look for other causes for those clinical signs. So who will treat Marvin for hypothyroidism based on the history and the test results? Raise your hands. So few of you. And who then, should I presume the rest won't treat Marvin for hypothyroidism? We need more data? So this may suffice, okay? So you have a dog that put on weight and is lethargic, and you have these test results. So then I would say you won't treat for hypothyroidism. But I would say either answer is fine, okay? It's okay. Why the no answer is fine? Because again, this dog has some signs of hypothyroidism, the weight gain and the lethargy, and the test results are below the normal reference interval. However, it's slightly below the normal range interval, okay? So that's what I want to call your attention. I've seen lots of clinicians treating dogs for hypothyroidism who did not have the disease because they based on the test results, and often they were just slightly below the normal reference interval. It should be significantly lower for you to consider treating for hypothyroidism. But let's say you said, okay, I won't sleep at night. If I don't, do a treatment trial. It's okay for you to do it. But the important thing, and we'll talk about treatment trials later on, is that you recheck this dog. And if the clinical signs did not improve significantly at the recheck visit, which should be 6 to 8 weeks to give enough time for the signs to regress, remove the medication. Why I'm saying that? Because again, I've seen quite a few dogs that were misdiagnosed with hypothyroidism and were left on the medication for a long period of time, life, okay? And we have to remember that this hormone affects almost every single cell in the body. And so you should not take this very lightly, okay? But let's see here further. We'll come back to that. So what I'm going to overview today is just to refresh your memory about the hypothalamic pituitary thyroid axis. We'll review that. Functions of the thyroid hormone or hormones, the disease itself, the diagnostic test, how to treat it, and if we have time, we'll discuss with you a couple of cases and the takeaways. So the hypothalamic pituitary adrenal axis, it all starts at the hypothalamus. So the hypothalamus secretes the thyrotropin releasing hormone, also known as TRH. TRH goes to the anterior pituitary, and there it encounters the thyrotrophes and stimulates them to synthesize and secrete TSH, thyroid stimulating hormone. That goes to the circulation, reaches the thyroid glands, and at the level of the thyroid follicles, it stimulates the cells to synthesize and secrete the thyroid hormones, okay? So that's what this is saying here, okay? So here it stimulates these thyroid follicles to synthesize and secrete T4 and T3. One thing to keep in mind, all of T4 is produced by the thyroid gland. Only about 40% of T3 is produced in the thyroid gland. Most of the T3s are produced peripherally in the tissues through deionization of T4. Why this is important? It is important when we'll be talking about the value of the thyroid tests, okay? Just keep that in mind, okay? One other thing is the thyroid hormones, when they reach the circulation, they bind to proteins. So very small amounts are free. And this free portion, it's the one that's going to penetrate the cells and be active, okay? And will do their work. When the thyroid hormones reach a level, okay, a homeostatic level, it will go back, do a negative feedback at the level of the pituitary gland, and will tell these thyrotrophes, stop producing TSH. Okay, so that's how that hypothyroidism, did I do anything? Okay. Pituitary thyroid axis work. Now, a little bit about the functions, the very functions of the thyroid hormones. So this, let's see, I have to get used to this too. So it increases the metabolism of almost every single cell in the body. Important for us to know, because then you can understand better the clinical signs, okay? It participates in the development of the skeletal and neurologic systems. It has a chronotropic and inotropic effect in the heart, because it increases the numbers of the beta adrenergic receptors, so make the myocardium more sensitive to catecholamines, okay? So that's why in hypothyroidism, one of the clinical signs is bradycardia, okay? So it stimulates erythropoiesis by participating in the activation of erythropoietin, okay? It stimulates the synthesis of proteins and enzymes, okay? And participates in the metabolism of carbohydrates and lipids, okay? So very important hormone, and as you can see, it affects many cells and systems in the body. And that's why you should really have a high index of suspicion to start a dog on thyroid medication. Or if you do a treatment trial, it's okay to do it, but be critical on the recheck, and if those signs have not improved, take them off of the medication, okay? So causes of hypothyroidism. By far the most common causes or cases that you'll be seeing are dogs that have an autoimmune thyroiditis, called often as lymphocytic thyroiditis, or idiopathic atrophy of the thyroid parenchyma. And actually, some people believe that the idiopathic atrophy it's the end stage of lymphocytic thyroiditis. But those are the most common cases. So when we say primary hypothyroidism here, I said acquired, primary, it's affecting the thyroid gland, okay? There are a handful of cases published in the literature with secondary hypothyroidism, where the hypothalamus is affected. And these dogs have reduced secretion of TSH, but those cases are not well documented, so I'm not even include them here. And in dogs, tertiary hypothyroidism has been reported in people, has not been reported in dogs to this date, okay? So this is what you're going to see in most of your patients is acquired, primary, and the cause will be lymphocytic thyroiditis or idiopathic atrophy. Now, the neoplastic destruction is rare. So these cases would be a non-functional tumor, and that tumor has to affect both thyroid follicles for the dog to develop hypothyroidism. And more than 75% of both thyroid parenchymas need to be destroyed before they have the disease, okay? And rare, it's quite rare. Now, iodine deficiency in the United States, where I live currently still, we don't see that because the dogs typically eat commercial diets, well-balanced diets. Now more and more owners want to feed their dogs homemade diets, but most of the time it's a nutritionist involved, not all of the time. I was yesterday just hearing some of the cases. It seems like quite a few owners will feed homemade diet, right, to their pets. So the important thing is that the foods that they are feeding the pets have enough iodine. And what would be those foods? So egg, okay, dairy products, fish, and seafood. Or if they season the food with iodized salt, and that's probably should suffice, okay? But you may see more hypothyroidism due to deficiency of iodine in the diet than I see. And in those cases, the situation is only interfering with the synthesis of the thyroid hormone. So the glands would be normal, okay? It may happen that some of the dog that has a deficiency, a diet deficiency on iodine may have lymphocytic thyroiditis. But the parenchyma is intact. So if you correct that diet, the dog is cured, okay? Potentially. We don't know if there is any inflammation on the thyroid glands of that patient. What about medication? So one for you to keep in mind is potentiated sulfas, okay? Potentiated sulfas can inhibit an enzyme called thyroid peroxidase enzyme that's important in the synthesis of the thyroid hormones, in many steps of the synthesis of the thyroid hormone. So if you're using potentiated sulfas to treat chronic respiratory disease and you're using it for more than a month, you may start seeing signs of hypothyroidism in that dog. In this, the dog develops the disease. If you do the thyroid test, they will be classical for hypothyroidism. They start to lose hair, they develop the non-inflammatory alopecia, so be aware of that. But again, you're not affecting the thyroid glands. You remove the medication, the signs resolve. Okay, it may take 2-3 weeks for that to reverse, but it can happen. Propylthiouracil and methimazole that we use in cats to treat hyperthyroidism. So we're talking about dogs here because the spontaneous hypothyroidism is very rare in cats, so can induce hypothyroidism in dogs for the same reason. It also inhibits thyroid peroxidase enzyme. Okay, that's very important. So that's the acquired form of primary hypothyroidism. Relatively recently, we identified a congenital hypothyroidism in dogs. And due to mutation thyroid peroxidase enzyme, okay? And this other mutation was very recent. It was just published last year in two Shih Tzus from the same family. So mutation is sodium iodide synthoter, which again carries the iodine to the thyroid gland so the thyroid hormones can be synthesized. And the first one there, the mutation of the thyroid peroxidase, you're going to see more in toy fox terriers, rat fox terriers. Those two are really, really predisposed, but you can see now these other breeds. And again, the Shih Tzu one was diagnosed with mutation on this synthoter, okay? Iodine, sodium iodide synthoter. So you can see that, but here it's quite different because again, these dogs with the acquired form of the disease will develop the disease in middle age to older age. Hypothyroidism is a slow progressing disease. In contrast, they are born with the mutation, but you may start seeing signs after a few weeks that the owners notice that they are different from their mates, okay, litter mates. Okay, so that's what we'll focus today in the primary acquired form of the disease. So signalment, breed predilection, definitely, because there is a genetic component in the autoimmune thyroiditis or lymphocytic thyroiditis. That, again, it's the most common form of this acquired primary hypothyroidism cases that you'll be seeing. So Doberman, for sure. Beagles are prone to that. Boxers, for example, it's another golden retrievers in other breeds, okay? Age. That's typically, again, a range. You may find some cases a little outside that range, but it's rare for you to see a dog with acquired hypothyroidism at a 2 year of age, okay? Because it progresses slowly. A dog may have lymphocytic thyroiditis, inflammation of the thyroid parenchyma, without ever developing hypothyroidism because you need the destruction of at least 75% of both thyroid lobules to develop the disease, okay? Middle age to old age dogs. History, what owners will complain to you, okay? Hair loss. And the hair loss here, and I'll show you some pictures, are known inflammatory. And you know that. It's the pattern of hair loss that you see with hormonal disease. Cushing's the same thing. So it's non-inflammatory. It tends to be symmetrical, but don't rule that out if it's not quite symmetrical. And because it's non-inflammatory, it's not itchy. So itching is not present in hypothyroidism. I should say something here because can they become pruritic at one point during that disease? Yes, if they develop secondary bacterial infection and or malassezia and or bacteria overgrowth, which they are prone to develop. And then they start licking and they may chew and scratch at that point. But how the disease starts, which is so important for you in any patient with skin diseases, it's hair loss, that's what comes first, and no itching, and then eventually it may or may not develop itching, okay? The skin can become hyperpigmented, comedones often developed, scales may be present also, and the distribution, as Dr. Marcella mentioned, so important for us dermatologists. It really helps us kind of rank our list of differentials. Distribution is important. So, but what is the distribution here? And it's again similar for Cushing's disease. Spares the face, okay? So that's a hint for you. Hypothyroidism, however, rare cases will have facial alopecia. I'll show you a picture, but typically spares the face and extremities with the exception of caudal aspects of the hind legs. So you see the alopecia neck, trunk, and tail. Okay, so those are classic, but you probably know that. Just remind, oops, did I go here? So then you have weight gain without eating more, lethargy, exercise intolerance, and heat seeking. So those signs are related with that decrease in the metabolic rate. I mentioned before that thyroid hormones increase the metabolism of almost every single cell in the body, okay? Sometimes owners won't tell you specific these problems, okay? They come to dermatologists because they are concerned about the hair loss, okay? Then you start to be suspicious, the age, the pattern of the alopecia. You ask some questions, how did it start? So no itching, start with the hair loss. And then you start asking these other questions if they are not presented. Is he lethargic? Sometimes it's hard for owners because they think the dog is getting old, they normally sleep more, but you have to investigate more if, again, they don't present that to you as a concern. So clinical signs, what we are seeing, we talked about the lethargy, okay, and that sometimes I see a dog, again, a middle-aged dog, a little overweight, with this pattern of hair loss, non-pruritic. The dog lays on the floor the whole time during the experiment. The hypothyroidism comes to my mind in those cases for sure, okay? Again, they tend to put on weight without eating more. Reproductive signs, you may see most of the cases I deal with are neutered in the United States, but again, female may be an estrus or a hidden estrus, male reduced libido, okay, azoospermia or oligospermia may be reproductive signs that you can see. Neuropathy can be central or peripheral, usually in chronic cases that you see neurologic signs due to hypothyroidism. And not always you're going to see that, okay? Ocular signs also rare, but typically it's a deposit. So you see the cornea, you're going to see some whitish deposits. Those are lipid deposits due to the hyperlipidemia that they have, increasing cholesterol and triglycerides. We'll talk more about that. Cardiovascular, we mentioned, come back. We mentioned the important function of the thyroid hormone in the heart. And so you can see bradycardia, weak apex beat, okay? First degree AV block in some of these cases, okay? Again, thermophilia, just due to that decreased metabolic rate. And owners may not notice that. You can ask, is he looking for warmer places in the house, okay? In behavior, I to this date, I'm not quite convinced yet if alterations in behavior is related with hypothyroidism. What is reported is aggression, shyness, and I think they get upset because they are not feeling good. It's not the direct effect of the lack of the thyroid hormones centrally. So that's my belief, and I may be totally wrong. Okay, I'm sure you've seen that, just showing you some patterns of alopecia. It's hard to see in this dog here because the skin is hyperpigmented also. And he has some hair loss here, but that's a pattern baldness. So probably wasn't a very good picture for me to put here, not to confuse you, because I said it spares the face. And yes, it spares the face, with one little exception here. And look at the caudal aspects of the hind legs, but front of the legs, you don't see the hair loss there at all. And then the red tail. And again, this dog skin. Oh, I was looking at this slide again, and I said, this is not a good, why did I put this slide? Because it seems like this dog has inflamed skin, but he doesn't, I promise you, okay? And so, but look at the hair loss, okay? And also here, I don't like this picture, but anyway, and again, caudal aspects of the hind legs, extensive alopecia on the tail. And this is what I told you, that's exception, okay? Rarely you're going to see a dog with hypothyroidism developing alopecia on the dorsal aspect of the muzzle. Doesn't bother the dog doesn't know he has this, and so, but it has this kind of subtle alopecia there, okay? But this is rare. Okay, diagnosis. As Dr. Marcella said a few times, and you know this, how important it is the history and clinical signs for all of us. It doesn't, a general practitioner, specialist, to get to a diagnosis. This is crucial, okay? And here, I will tell you, don't even test a dog for hypothyroidism if the history and clinical signs make you very suspicious of it. Okay, if your index of suspicion is high, it's not high, don't even test it, okay? So, and then again, as we have a characteristic history and clinical signs, then we do this diagnostic test to try to support our clinical diagnosis. I put this here because for many years I've been saying hypothyroidism is overdiagnosed. And they just published this paper, which really showed that, and I said, thank you. So it's very interesting. It came from the UK, and 3 clinicians looked at 102 medical records of dogs that were on thyroid supplementation. And they wanted to know, should they be on thyroid supplementation? And again, there's quite a few details on the paper. It's very interesting. You should read it. But you can see here, so clinician 1, 2, and 3. Clinician 1 thought that almost 60% of the cases should not be receiving thyroid supplementation because it was misdiagnosed as hypothyroidism. Clinician 2, almost 73%, and clinician 3, 45%. So it is, unfortunately, an overdiagnosed disease. One thing that's good, it's because I'm starting to see less and less patients coming to me on thyroid supplementation, which should not be receiving it. So I think it is improving. People are starting to become more aware. Let me ask you a question. In your clinic, you have thyroid hormones as one of the tests in the chemistry profile? Any of you? Any? No? So it's not part, if you have it, so one person said yes, but that's the problem in the United States and in Europe too. They decided to add thyroid tests in the chemistry profile. So they are testing for hypothyroidism, a lot of these animals. And then they look at the number. It's a little below the normal reference interval, supplement. And so that's one problem, okay? So again, we have to remember we should not treat numbers, okay? The test results are very important for us to help us, but it's when, again, we are thinking of the disease where the clinical signs and history support that disease, okay? So, what did I say here? Yes, we'll talk about the clinical pathologic changes that can support our diagnosis, and then the thyroid tests. So, CBC, about 30% of dogs with hypothyroidism will have a normocytic, normochromic, non-regenerative anemia. So 1/3, okay? Very non-specific, right? So you see that with chronic diseases in general. Cholesterol and triglycerides, look at that. So the percentage here is very high, so it's high. And so if you have a dog with signs of hypothyroidism, you do some clinical pathologic tests, and cholesterol is high, fasted cholesterol and triglyceride is high, it increases, it supports your presumptive diagnosis, I should say, okay? But again, they are definitely non-specific findings, right? Now, there are lots of thyroid tests we can do, and I'll talk a little bit about each one of them, but before that, it's important for us to know what can affect those tests, which can confound the diagnosis. So mailing the test results, okay, and then people sometimes supplement them in situations that they're not paying attention to these factors, and the patient doesn't have hypothyroidism, okay? So non-thyroidal illnesses, it can lower total T4, lower free T4. Very rarely it increases TSH, because this is the classical result of a dog with hypothyroidism, right? Low total T4, low free T4 by equilibrium dialysis, and TSH should be high, because lack of that negative feedback, the hypothalamus, the pituitary doesn't know that, it keeps producing TSH, okay? So now, the illnesses, non-thyroid illnesses, usually moderate to severe, okay? The body will reduce T4 and free T4. Why? To save energy to cope with that disease, okay? So it's normal. But if you are measuring thyroid hormones in a dog that's sick, it will be low. And you know, in people, this occurs in people also, if you supplement a person that has a severe disease, thyroid hormones are low, you worsen the prognosis, okay? This most likely will happen with dogs too. So think of diseases, moderate to severe disease. Don't test a dog for hypothyroidism yet. Treat, and then wait 2-3 weeks and test if you still think the dog has hypothyroidism. So drugs, look at the drugs. Drugs that you use commonly in practice can affect the thyroid hormones. The most important one here that I put it there, potentiated sulfas, okay? That one induces reversible hypothyroidism, okay? But keep that in mind. It's still important here, age. Older dogs will have lower thyroid hormones, normal. We older people, we have lower thyroid hormones, okay? Our metabolism in general reduces. So, but is it that low? Does it go low as you typically see with a true hypothyroidism? No. It will be below, can be below the normal reference interval, but mild, slightly below, okay? Now breed. Sight hounds, so greyhounds, Afghan hounds, Saluks, and other the sight hounds normally have thyroid hormones below the normal reference interval. And that's the thing. When we establish reference interval, we get 100 dogs, all different breeds, and get the values, establish the range, and we think we can apply this for the whole population. So ideally what we should do is to establish breed-specific references interval for the thyroid hormones in dogs. But we don't have that. Random fluctuation, we usually measure at one point in time. So it could be that that dog does like that. Here it is within the reference interval, and then go a little bit below it, and then go back. And that's why it's okay, like the Marvin case. It's okay. It doesn't mean hypothyroidism if it's slightly below that normal reference interval, okay? I want to see the typical history, typical clinical signs, and the levels very low. And then I said, yes, hypothyroidism. But I don't see that very often. Why? Because it's not a very common disease, okay? So, and fasting. The body is smart. So if you fast for more than 48 hours, it reduces the thyroid hormones to save energy, okay? This is very new. I put it here because I listed for you some of the medications that can affect the thyroid hormones. And this is an updated paper, okay? But I was looking at the drugs. It's not very different from what you have, but it's interesting for you to have this paper. So how reliable is total T4? I presume that that's probably the most common hormone, that you measure, I really like total T4. So it's very sensitive, okay? If the dog has hypothyroidism, that will be low. And as I mentioned to you, if the reference interval is 1 to 4, it will be 0.5, okay, maybe 0.6, or even below that. I had cases that non-detectable. The laboratory was so low that the sensitivity of the test could not pick that up, okay? However, what can be the problem here? It's the diseases and the medications. That's why you have to pay attention when you're testing the dog. The dog is healthy. Otherwise, it's not on any, you check your list, not on any medication that could affect the thyroid hormone. So if it is low, my history and clinical site support, yes. So where are we here? So if it is low, again, history supports, clinical sign support, go ahead and treat, okay? If the drugs or disease is there, treat, remove, wait 2-3 weeks. If you still believe it's hypothyroidism, retest, okay? Again, if it's normal, you can pretty much rule that out. There is one exception that's rare, because again, I mentioned to you the autoimmune thyroiditis or lymphocytic thyroiditis is very common. It's a very common cause of hypothyroidism. The body produces antibodies primarily against thyroglobulin, where the thyroid hormones are when they are, again, in the follicles before they are released. And rarely they produce hormones against T4 and T3. And in that case, depending on the assay that the laboratory is doing to measure T4, then the value can be seriously high. And then you can miss hypothyroidism in this case, okay? And then what you can do is the free T4 bioequilibrium dialysis, because the dialysis membrane will won't let large molecules like protein, and antibodies are protein, to pass through. And you are measuring just free T4 in those cases. But this is a rare situation, okay? So very good screening test. I still like total T4, but again, I'm very careful. I looked, any diseases here that could be affected or medication. If it's not, it's a good test. And again, that's exactly what we saw. What about free T4 bioequilibrium dialysis? Some people thinking, yes, it's the best test ever. I say, I don't see a lot of difference, honestly, between total T4 and free T4 by dialysis. Yes, maybe it's less affected by drugs and disease than total T4, but it's still affected. And you have to pay attention to that too, okay? Again, very sensitive and good specificity because it's less affected than total T4 by these factors. When it's low, hypothyroidism, it has a high negative predictive value because sensitivity is really good and it's more specific, okay? Now, I think Jairan told me that you don't have the T4, the total T4, the free T4 bioequilibrium dialysis here available to you, correct? Do you have that test? So honestly, if you don't have the free T4 bioequilibrium dialysis available to you, and if it's a more expensive, what you have available is more expensive than total T4, I would say I would go with total T4. Huh? Oh, RA8. Okay. Uh-huh. They said that it's as good as the equilibrium dialysis. You said that RIA. Oh, IDEX. Okay. So do you know which method they use? No? Did you tell me that already? So we'll talk. But if it's not by equilibrium dialysis, I would say you're not gaining much than total T4. And if it's a more expensive test, I will go with total T4. That's my opinion. So, but you don't need to take. So best single test. That's what people say. I'm not sure about that. So what about TSH? TSH is what's done in people. And so they don't do total T4, they don't do T3 or reverse T3, they do endogenous TSH. When this test became available to us, we said, yes, it's going to be better than total T4 and better than free T4. Okay, so I actually don't recommend you requesting this test as a sole test. Why? Sensitivity, it's not good. Look at this here. 20 to 30% of hypothyroid dogs have normal endogenous TSH. And it should be high, right? Because again, the hormones are not being produced, no negative feedback at the level of the hypothalamus, and TSH should be high in those cases. And it's normal, so bad sensitivity. Why do we use it? And we use it combined with total T4 and or free T4 by dialysis to increase the specificity of this test, because endogenous TSH is less affected by medications and diseases, okay? So, and again, if it's high, and look at this here, just to complicate also, about 15% of normal dogs will have high TSH. That's what, as a sole test, don't do it. And so, but it can be used with other tests, okay? And that's what is there. What about thyroglobulin autoantibody? So, again, 60% of thyroid dogs have positive thyroglobulin autoantibodies. Again, you're diagnosing lymphocytic thyroiditis. It's a very good test. It's a sensitive test. It's a specific test. It's done in the United States by the breed clubs, because there is a genetic component, and they want to know if the dog has the antibody against thyroglobulin, okay? Because that's a marker for lymphocytic thyroiditis, okay? But positive TGAA does not mean hypothyroidism. It means the dog has lymphocytic thyroiditis. But again, remember, for the disease to develop, you need to have destruction of both lobules by at least 75%, okay? So this paper just came out. There was an old one published more than 20 years ago where they looked at dogs that were positive for thyroglobulin autoantibody and to see if eventually they developed hypothyroidism. In that paper, they said 20% within 1 year. That's how far they went. And this paper went farther, 1 to 9 years, and about 30% will develop hypothyroidism. So it's not a lot of them that will develop hypothyroidism within their lifespan. So what about total T3? That's why I mentioned to you thyroid gland produces about 40% of total T3. Most of total T3, that's the most important biological hormone. What does it mean? That's what enters the cell nucleus and do what's supposed to do, okay? But why it's not reliable? If the panel that you have has total T3, ask them, I don't want it, would you charge me less, okay? Because it's not a good test. Why? Because what's measured in the blood, it's not reflecting what's in the body. Because most of it is inside the cells, okay? Not very good. TSH stimulation test, that's the best gold standard test. Unfortunately, I'm old, so I used to have easily available bovine TSH. Nowadays, you cannot find it, okay? Why it's the gold standard test? This is you're stimulating the thyroid gland to produce the hormones. So it's checking the reserve of the gland, so it's beautiful. Now, we can only use the human recombinant TSH, which was validated for dogs a little while ago, extremely expensive. One bottle, so after you reconstitute, you have to freeze it because it's not very stable. Last time I checked, $1,400, $1,400. And that's what they use in people, okay? And again, they measure endogenous TSH, but they use it for some diagnosed Hashimoto's to some extent and other diseases there of the thyroid. And so, but again, very expensive. Then we don't use it routinely, Because again, if you buy a vial, you have to have quite a few dogs suspicious of hypothyroidism to be worthwhile what you're paying. So treatment. I'm okay with time here, I hope. I'm not going to look. Okay, use the brand name L-thyroxine, okay? You can do generics if, again, there is a huge difference in cost and money is a concern for the client, but I prefer, at least when I'm in that phase of really diagnosing it, to use the brand name product, okay? So the dosage is 0.02 milligrams per kilogram twice a day. If you have a larger dog, where when you calculate, the dog would receive more than 0.8, stay at that dosage, okay? Don't go over 0.8 or less, because you can make the dog have thyroid toxicosis, okay? So they lose weight very quickly, they drink more water, they are hyperactive, so, but that's if you have, again, a dog, let's say 45 kilograms or more, okay? So after that, you recheck in about 6 to 8 weeks, okay? I like to wait a little bit to make sure the hormone will work in the signs that made me suspicious of hyperthyroidism. If the dog truly have it, would be improved, because it may take a while for the weight loss to occur, and even for the hair to regrow back. So you can recheck a little earlier than that, a month. I wouldn't recheck sooner than a month, okay? But one thing which we will talk about, the activity, in a minute here, but the activity level, however, exercise intolerance, lethargy, improves within 10 days, 10 to 14 days, okay? So what I do, I start the dog on supplementation, schedule my recheck. I'll tell you how important to schedule that recheck. I do that when the client is in the room, and I call the client, ask them to call me. If they don't call me, I will be calling them. I put it there in my notebook in about 10 to 14 days. And ask, is the dog happier, more active? Okay, because you should see that improvement early, okay? Skin takes a while, the weight loss takes a while for you to see noticeable improvement, okay? So then you see here, 4 to 6 hour post-pill. That's why when you schedule the recheck, make sure that check with the owner, when are you giving the pills? And make the appointment about 4 to 6 hours post-pill. If the client has to change that schedule to be able to make the appointment, make sure he will be giving the thyroid supplementation for maybe 4 days with this new timing before it comes, okay, for the recheck appointment. Why 4 to 6 hours? Here we are measuring the peak level, okay, of the thyroid hormone. I'm only measuring total T4. Some people do total T4, TSH, I said, no, you don't need to. So only total T4, okay? So 4 to 6 is the peak. And then we want to see it in the high end of the normal reference interval. And it's okay to be a little above it too, okay, if the dog has no signs of thyroid toxicosis, okay? Because again, after that, it will go down. And so that's why we want it in the high end. And you want to make sure that you have enough in the body until he's due for the other dosage, okay? So, but then this is, see, if it's no response, okay, you recheck, you're disappointed, no response. The owner also disappointed. So you do your post-pill, the 4 to 6 hour post-pill. So if it's high normal or just about the reference interval, reconsider your diagnosis. The level is good. You had enough time to see improvement. You didn't see the improvement. Think of another disease there. So if it's low normal, increase the dosage and recheck in 4 to 6 weeks. Every time you're changing dosages, you recheck and reevaluate the hormone level again, okay? If you don't see no response at that time, reconsider your diagnosis. So positive response, excellent. And post-pill, high, normal, or less than 40% above the reference interval, continue treatment. And we check maybe 6 months, but educate the client. If there is any recurrence of signs, let me know. So you see the patient before that. So if it's above by more than 40% and you are seeing signs of thyrotoxicosis, the dog is skinny, it's drinking. The owner said, I cannot handle this dog at home. He jumps, he puts his hyper. And so they drink more water, also reduce that dosage, okay? But again, if it's a little above and he's not showing those signs, we are not, again, making decisions based on numbers. Patience is the most important thing, and we leave it as is, okay? So then we are here. Reduce the dosage or give it once a day, okay? But you're changing the protocol here. Recheck in 4 weeks, okay? And again, and then make decisions based on the patient at that time, okay? If it is low normal, okay, then you're a little concerned, oh God, this dog will eventually develop signs again because he may not have enough concentration until he's due for this other dosage. So you can increase the dosage, I would say by 20-25%, and recheck again. You could just observe. The dog is doing well. If you have a good communication with the client, just check, educate the client, what the client has to look for, okay? Or do a trough, which means you get the sample before he's due for the next dose. And that can be a little complicated to schedule. And so, and if it's within the normal range, reference interval, great. I don't need to. If it is below that, no, I need to increase that dosage, okay? If that makes sense. Again, activity level in 1 to 2 weeks. Obesity takes longer, and dermatologic signs takes longer, okay? What about the treatment trial? And I said, you can do it if you want. It's like, okay, there's some signs of hypothyroidism. The test results are inconclusive, and you said, I won't sleep at night if I don't start this dog on thyroid medication. Go ahead and do it. But recheck, okay? Be critical. Are the signs significant improved or some of them resolved? Remember the activity level? That should resolve early on. Check with the client. But still recheck the patient in about, again, can be a month, 6 weeks, 8 weeks, okay? And again, measure. So, oh, good. We'll do here. Measure T4, 4 to 6 hours at the peak, okay? And again, rule out if no response and post-pill T4 are in the high end of the reference interval. Because then again, it's high enough, but he didn't respond. It's not hypothyroidism, okay? Okay, it's just because I think in your notes, I had this as micrograms. Okay, so it's milligrams. It should be 20 micrograms, but it's 0.02 milligrams, okay? Otherwise, you'll be giving too little. Oh, what happened here? Okay. Do we have time for quickly, promise? 2 cases. Yep. 1 case. 2. Ay. So, 1.5-year-old, neutered. This one it's very easy. The other one I was just going to quiz you to see if you are paying attention. So, bull terrier. Hair loss on trunk, neck, face. Signs began with itching, then hair loss, and then red bumps and scales. Current medication, primer, potentiated sulfa. So here it is. You know the answer, right? Based on his history and clinical signs, would you test him for hypothyroidism? See, if you are going yes, let me know. Beautiful. Then you guys will not. Now you have to justify. Tell me why. Age, okay, too young. And so, even it was congenital, no, that dog has it's itchy, red skin, and so, no. So, clinical sign? The breed? Don't, huh? Fleas. Oh, the face, thank you. She was paying attention. So, face is affected. So the age, the lesions, the skin is very inflamed. Hypothyroidism is a non-inflammatory disease. Distribution, face was affected. And let's say everything looks good, clinical signs suggestive of hypothyroidism, history suggestive of hypothyroidism. This dog was on primer. Would you test the dog? Yes. That day? Yes? How many of you would say yes? Jairan? You should not. Oh God, no. But why? Why not? Hypothyroidism itself can cause hypothyroidism. It will be confounding to you. If the dog was only 1 week, don't worry. But if it was on 3 or more, I would say a month or more, yes. So do you have the other case there? I know they won't let me do it. So, okay, so the other case I was just going to test you.
3 minutes. You have time. I put a time.
Okay, no, and then we have the justifications here. You guys did beautifully. Okay, oops. It just again, right? It's our bread and butter. Now, this dog, you diagnosed a 10-year-old female spayed Sheltie with hypothyroidism. You started her on 0.02 mg per kg, 20 micrograms per kg, twice daily supplementation. Which clinical signs would you expect to improve first? Activity level. You are paying attention. Thank you. Okay, activity level. How soon again? Okay, you got it. Okay. And then, when would you schedule a recheck appointment? Okay, 4 weeks. I probably said it a little longer, but that's fine. Okay. Call in 10 days and check with the owner, the activity level. Okay, how many hours post-pill you check? 4 to 6. Thank you. So, yes, 4 to 6 hours post-pill. You do that when it's taken twice a day. If it's once a day, it's different. We'll see that. Yep, beautiful. Where you should see the level of the thyroid hormone. So you have the reference range here, high, right? Because we are measuring the peak. Yes, so you don't be surprised if it's a little above it, okay? But if the dog doesn't have signs of thyroid toxicosis, leave it alone, okay? Yep. Now, if it's once a day, so I don't like to start once a day. I will go twice a day. Rarely I change to once a day. But some people say, okay, let's see if this dog will metabolize the L-thyroxine differently and the effect will last longer. So you could do that. Let's say you did it here. Now, 4 hours? 6 to 8 hours. We still are kind of in the peak there. So it's the trough, just before he's due for a dosage, because you want to see if the hormone level lasts in an adequate concentration until he's due to another dose, if that makes sense. Okay? So then, okay, just due to take the pill. You have to schedule all that. Sometimes it's so. And at what level do you want to see? Anywhere within the interval. Most likely here would be within the lower end of the normal. Yes. Okay? Okay. Done. And then you have the takeaways. I think you have the takeaways there. Otherwise, Jiran is going to kill me. Okay.